And over the next 8 years or so, my bones deteriorated again until I really upped my protein, upped my lifting, and now I have healthier bones than most men my age of 64 without using any further medications.
Hello, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Chris Link. Welcome to the show, Chris.
Thank you very much, Gil.
Chris Link is incredibly well known here in mid-Missouri. He runs the Integrative Medicine Clinic in Jefferson City, and I have fond memories of my mother when she was alive, coming back from visits with Chris, and she really appreciated your care, and you took great care of my family, Chris, so I want to thank you right off the bat for that.
It was an honor. Your mom was a force of nature. I was glad to get to know her. Very interesting and powerful and widely read and just interesting woman.
She was a very interesting woman. She was a force of nature, and this is going to sound all woo-woo, but I'm going to say it. I was in her presence. I was coming to the house when she died, the moment she was dying. The sky parted. It was a cloudy night. The clouds parted, and the full moon was right there. And this wind came up. In fact, I was in the Colorado Rockies snowboarding, and they canceled my trip because gale force winds came up and literally blew all the snow off the mountain. So I came back a day early. I got there when she passed, and I felt her spirit leaving the earth, going to the moon, and then the clouds came back together. It's giving me chills. She was a force of nature, and I'll never forget that moment.
It sounds like nature was shining on her at the time of her death with the sun parting through the clouds like that. What a great story.
Yeah. You can say, well, that's woo-woo or something. I saw it and I felt it. It was just, she blew the snow off the Rockies, got me home a day early, and there I was there to watch the transition. Just amazing. So, Chris, I'd like my audience to learn a little bit more about you. You're a native of the St. Louis, Missouri area. You went to SLU, which is St. Louis University, for medical school?
I did indeed. It was great. I mean, I lived as a child not too far from there, and I remember taking the bus or walking on the street down Grand Avenue, South Grand Avenue, and looking up at that building and seeing the activities in there, and even driving by there at night, seeing the lights on, and kind of wondering what might be going on in that medical school building. Well, I got to find out after spending many, many hours there, particularly in the anatomy lab. It was a great deal to go to medical school in my hometown.
That's great. I know football players will go by Faurot Field, our college football stadium here, and dream of playing there or whatnot. So it's the same idea. So you went to medical school there, and then you did a year of internal medicine internship, and then you went up to Wisconsin for an actual residency in emergency medicine and trauma. Is that right?
I did indeed, and that was a great place to learn in the city of Milwaukee, where there's so many things, so many people who needed care, and unfortunately a lot of trauma there too. But it was a great opportunity to learn emergency medicine, and it really set the stage for me to practice that, as I did for almost 20 years.
So what happened? Well, how did you have a shift in interest from emergency medicine with its fast-paced, high-stakes kind of environment to something a little more, let's say, laid back or thoughtful or slow-paced, like family medicine and integrative medicine? What was there a shift in your life or your interests?
Well, the truth is, Gil, emergency medicine almost killed me.
It almost kills a lot of people.
There was a lot of, there's a disruption of your circadian rhythms with working nights and evenings and things like that, and the stress and the strain of it, and the anticipatory anxiety before shifts. I was a very good emergency medicine doctor, but it really started to work on my nervous system, and that manifested actually as some chronic pain related issues that I had, and I really needed to be done. And in 2009, in February of that year, February 26th was my last day in the ER, and it was a great time for me to move on to this. I had done some preparation. I did a fellowship in integrative medicine through the University of Arizona, and that really set the stage for me to open my own practice.
So you were still an emergency physician, and then while you were doing that, you took this 2-year fellowship with Dr. Weil?
I did, yes. And at the hospital where I worked at Capital Region in Jefferson City, some of the board members actually were interested in integrative medicine and being able to offer that to their patients. One of the reasons why I was told years later was because one of these women had breast cancer, and she wanted other things. She certainly wanted the standard, the best care related to that in allopathic medicine, but she wanted more than that. She wanted some nutrition and some mind-body stuff and other things to really support her journey through the cancer care.
Yeah.
And when they knew that I was taking that fellowship, they then offered me a position to open the integrative clinic in partnership with Capital Region Medical Center, and it was
they recognized the need, and there you were getting ready to fulfill it. And let me tell you something, Chris. I really admire you for recognizing the toll it was taking on you. We hear too often about a doctor that actually burns out, and they go through the whole burnout phase, and God willing, they come back in another incarnation if they live to tell about it. And you were insightful enough to recognize that and make the shift in your personal life. That shows great maturity and insight. So you did the
and I might add courage.
Please.
I might add courage on my wife's part to
Oh,
allow me to make
it's
the transition.
scary.
We had 5 kids. We had a good income as an emergency physician. Things were going to change in a big way. Well, it turned out just fine, but there was it was a step, and I think a bit of a leap for her. But she believed in me, and it made a difference.
Oh, I mean, it is a stereotype or a saying. Behind every great man's a great woman. But it is so true. It's true in my life too. I couldn't do what I do without my supportive wife. I'm so glad you had that too, Chris. So then you shifted to integrative medicine, kind of family practice with the integrative bent and all those other things you bring in. And you started your clinic when what was the date you started the integrative clinic?
In August of 2009.
2009.
So I took a few months off and got things ready and things open. And it was, within a few weeks, we started getting plenty of calls. And within 6 months, our clinic was full. I was surprised, but there was an amazing amount of interest in it, and interest in it with folks that you might think, people that are really into health and exercise and nutrition and vegan diets and all of these sorts of things. But it was also, very interestingly, a lot of the rural folk that just had they have a heck of a lot of horse sense, and they wanted to do other things and just rely on medication to take care of themselves. Now, integrative medicine brings together nutrition and exercise and mind-body and medication when needed. And clearly it's needed at times. And putting those together, you tend to use less medications, but you need them at times. And to be able to do all of those, to be able to use all of the tools that we have to help people is what integrative medicine really, where it does the best.
Well, I'm not surprised it took off. It's always a leap of faith opening a clinic, but it sounds like you had the support of the administration there, and to get real busy in 6 months is quite a testament to the need and to your acumen and the services you were providing. So I assume you treat a wide variety of conditions.
We do. It's right. It might be, as you mentioned, like a family medicine clinic where I treat people of all ages, except for the neonates. Children typically over 1, and I have a patient that's 102 right now. So a wide age range, and then all of the common things you might see, from mental health concerns to cardiovascular concerns to bone health concerns to endocrine concerns, thyroid disease, a lot of GI related issues, musculoskeletal issues.
Wow.
So Yeah, it's great fun. It's, the best part of it, Gil,
What?
is to partner with the patients, to help them.
Yeah, the relationships.
It really makes, it's certainly, there are brief relationships that you create and rapport in the ER that's really important to gain the trust in a person that's in a serious condition. But what you do over time with patients, and sometimes they have needs, sometimes they don't, and you just work with them, and it's a great honor, as you know.
It's a great honor and a privilege to provide medical care. And certainly, when I was a medical student, there's a few things that stand out in my mind. One was when hearing the helicopters coming for trauma. And when I was young and I didn't need sleep, I thought that was really sexy and exciting, and thought about being a trauma surgeon for a couple days. I'll never forget, as a medical student, helping a neurosurgeon when the skull came off and there was the pink pulsating brain right in front of me, and I kind of got shocked there, and the neurosurgeon goes, "Pay attention!" He snapped me out of it, because I was kind of mesmerized. But he knew that. He knew that. And I also remember doing my family practice rotation and being very intimidated by the breadth, the incredible variety of conditions that these family medicine doctors were seeing walking in the door. I could just, it was everything. And I found that very intimidating. How are you going to know everything like you guys know? So I have a tremendous respect for primary care and a family doctor, integrative medicine doctor like you that can see all these things and treat them well. So we could talk about any number of conditions or diagnoses or illnesses. But after going back and forth with you, I think we would both like to chat about a condition called osteoporosis. Would you like to talk about that with me?
I would. It's
Chris?
It's a area that I think I've become a regional expert in it because I put the time into doing it. And a few years ago, Gil, I was sitting with a patient and I realized, and actually throughout this whole day, I realized that every single patient I saw that day had bones. Every one of them.
Yeah, it seems to be a common denominator.
It is indeed. So there, one in 3 women will have an osteoporosis-related fracture in their lifetime.
1 in 3.
And 1 in 5 men will have an osteoporosis-related fracture. So it's really, and that's just not osteoporosis. That's really the most severe manifestation of it. So it's really, really common, and we can do a lot of things to reduce that.
So let's talk about, I'm into word origins and what do words mean. Osteoporosis. Osteo means bone, and porosis is the same root as porous. Something has open spaces in it. So bone is a dynamic organ. People don't think of their bone as something hard and fixed. It's not. It's constantly getting regenerated, resorbed, regrown. It's a dynamic structure or tissue, right? And if the absorption goes faster than the regrowth, then the mass or the mineral content or the structure of the bone gets weaker and weaker and lighter and goes through osteopenia. Penia, I believe, means low amount. You can have sarcopenia, which is low amounts of muscle, osteopenia, and then the bone becomes porous and open and weak, becomes osteoporotic and prone to fractures. And fractures are a nightmare, particularly if you're older, aren't they?
They're a nightmare. And we know, and this is a drastic example, but a person in their 70s that has a hip fracture has about a 50% risk of dying in the next 12 months.
Of dying. And we say, how can that be? It's my hip. How come I'm dead? So up to 50. Well, I heard even maybe over. I guess the older you get, the higher. I know if you have a really old, frail person, a hip fracture is.
Yeah, I think, and that's really what tilts it. For somebody that's vigorous and they have good strength and generally good health, if they're in their 70s and break their hip, they're going to do okay. But most people who fall and break their hip, they not only have the osteoporosis, but they have the sarcopenia that you mentioned, the frailty, and probably some other organ deficiencies that is going to make it more likely. And then, with the hip fracture, you're going to lose more muscle. You're you're at risk from being more sedentary at that point and developing pneumonias and other things like that.
So
it's a big deal.
It snowballs. It just kind of pushes you over the edge into decline. So osteoporosis, incredibly common. So osteoporosis develops over years. It generally doesn't happen overnight.
And interestingly, when I think about your practice, taking care of young families and young women that want to get pregnant, really we need to be thinking about osteoporosis even before then, because you need to develop, you develop your bone mineral density, your bone mass, that reserve of bone. You do that in the first 2 decades of life. So being active, getting plenty of sunshine and protein and vitamin D and other things to really establish that core. And then, like you said, the bone is really very dynamic. It is always breaking down in building so that if there's microfractures or injuries to it, it can repair that. But it's other than that, it's a resource for our body for calcium. So you think of again, your patients, those women who become pregnant, they're giving some of their bone mineral to that child.
Yes.
And then when they're lactating, they're giving a lot
Even
of that.
more. So it's leaching out of their bones.
And there's a tremendous dynamism in bone at that point. They may lose 10% of their bone density during pregnancy and lactation. It's impressive. But the other thing is impressive is in those young women with the normal hormones, the normal activity, that within a couple of years, they're able to restore that. That's how powerful that recovery is at that young age.
Wow. So being active, weight bearing, I don't necessarily say weightlifting, although most of us advocate some type of weightlifting. Certainly holding a baby, carrying it around is weightlifting. And having a good nutritious diet with lots of protein and obviously calcium, vitamin D, really, really important. Now, I know the American College of Obstetrics and Gynecologists recommends that women wait about 18 months, about a year and a half between babies, in part because that's the time it takes to rebuild the skeleton.
The bones probably and the brain, right?
The brain.
Right, because the brain changes too, related to lipids and omega-3s that they give the child, and maybe that has something to do with the postpartum depression they have. So I think that is a good idea that they wait.
If they have time. Now, ladies I take care of, they're in their 40s and they've got very little time, and they'll say, hey, there's a recommendation to wait 18 months. I'll say, well, ma'am, eat as good, eat as best you can, start lifting weights, and maybe in 6-8 months we can start, but with the full knowledge that it can take its toll.
So when these mothers have these children, they're probably thinking about how they can help their children develop the best bone densities they're getting, because not only are they concerned about them, they probably may have had a parent or so that had, or a grandparent that had osteoporosis, and their children, they want to keep them active. And active in different, in a variety of different sports is probably best. We know that children that, they'll play soccer and they'll play baseball and they swim, the variety of different things leads to healthier bones, different sort of forces on the bone, so they're less likely to get things like stress fractures and things like that. And so they can build a really good bone reserve by the time they're 20. And then in your 20s and 30s and 40s, you want to stay active and you want to
maintain that bone mass.
Yeah, maintain it for sure. You want to stay at a high level.
I'm glad you mentioned getting sunlight. So many doctors, including one, I don't want to name names, but it generally, all you hear is to avoid sunlight. And there certainly is a vocal minority, probably you and me included, that said, no, we need to get out in the sun and have, safe, they'll say there's no safe amount of sunlight, but clearly there is a safe amount of sunlight, in my opinion, that we can get. We go outside, because the sport's not only circadian rhythms and tanning and mood, but also supplies vitamin D in addition to mood elevation, doesn't it?
Yeah, vitamin D is the key, and getting a certain amount of sunlight is very reasonable. Not enough to burn, but enough to maybe get a slight pinkness to your skin, which is 15 to 30 minutes, somewhere in the midday region.
Yeah.
But one of the keys there too is that here we are in late October. Right now, the sun is so low in the sky that the sun imagery is insufficient really to create enough enough UV light to actually create the vitamin D.
Yeah.
There's that period of time between about late September and late March where even if you stand outside on your roof at noon, right, with in a bathing suit, if it's not too cold, you're not going to make much vitamin D.
Not
So
going to
you
make
need to,
much.
yeah, so you probably need to, for most people, they need to supplement that.
So okay. So the importance of growing good bone when you're younger, maintaining it in more, I don't want to call it middle age. In middle age, the older I get, the later middle age becomes. But maintaining that bone as you get older. And you've mentioned how women during pregnancy will lose a lot of their nutrients, a lot of their resources and bone to the pregnancy and the baby. So let's talk about nutrition during pregnancy. Now, you had mentioned veganism here, and I know a lot of people eat vegan hoping that it'll make them healthier. I'm of the opinion that maybe there's some people that can do well on a vegan diet, but some people, I think myself included, that really need meat and animal products for the protein and whatnot. What are your feelings on various diets, Chris, and how they might impact bone and skeletal health?
This is a big part of my practice. I use nutrition as a foundation to help people with all sorts of conditions, and I use a variety of different diets. I mean, rarely do I recommend a vegan or a vegetarian diet. I certainly recommend a lot of vegetables.
Okay.
But I recommend all the way to the carnivore diet, depending on what I'm trying to eat, trying to help the patient achieve.
Okay.
But the bottom line is it's pretty simple, and we can keep it simple. You want to eat whole food, real food, number one. You want to avoid processed foods. Those are the two keys. We can arm wrestle. There's different, different groups that would die in a ditch for this diet versus another diet. But the truth of the matter is that you just want to eat real food, whole food, and you want to eat, and you want to avoid the processed food. If you do those two things, a lot of things get better.
A lot of
cardiovascular disease, metabolic disease. You're going to have a whole lot, better nutrient quality of your food. Now, whether you eat animal products or not, that's certainly a real personal concern for people, and they may not want to do that. But what you really need to do is get the protein.
Yeah.
And for most people, it's about 0.8 grams per pound. So if you weighed 150 pounds, that's about 120 grams of protein a day. And if you get it from an animal source, as you know, that's readily digestible and absorbable. If you get it from a plant-based source, it's less absorbable. And they don't have all of the amino acids that you may need really to build muscle. You don't get enough methionine or lysine and certain key amino acids. So if you lean towards a vegan or a vegetarian diet, you need to probably up that to like 1.2 grams per kilogram and get more like for a 150-pound person, more like 150 grams of protein a day, because those other, plants they have barriers to the ability for us to absorb the protein from them.
They don't want to be eaten. Plants don't want to be eaten. And they've got all these phytotoxins. Yeah.
Right.
So I think it's fair to say, however, that good or generous amounts of protein intake throughout life will translate into stronger bones later on?
I think so. Absolutely.
Yeah,
because, when we think about what osteoporosis is, the porosity that you talked about, bones aren't just the mineral. They're not just the calcium, right, and the magnesium, right? They're the lattice structure. That's the protein.
That's protein made of collagen.
Lots of collagen.
All stuck together, woven together. All these cross links. It gets to become fancy biochemistry. And you have to know that if you're doing these various tests to see if
now, I'm a little older than you are, and when I was in grade school, we had chalk, and where we went up to the chalkboard, and that chalk was pretty brittle. It was really easy to crack it in half.
Yeah.
Right. And that's calcium carbonate, as you know.
Right. It can be heavy.
And it can be heavy, but it is not very strong. And so that's why we need much more than calcium. We need the protein for our bones, and that combination makes the difference. And we'll get to exercise a little bit as we go forward here, but the resistance training actually helps the bone absorb and utilize the protein better as it helps the muscles. When you give a stress on the muscles and the bones, it makes the anabolism, the building of the bones and the muscles. It's the stimulus we need for that. And
what a great word, anabolism. I love that. I hear catabolism all the time, but anabolism, what a great word. What a great concept to grow. To grow. And it is these little microflexations, make little electrical currents and whatnot. And it's that whole dynamic that creates this anabolism. Well, that's going to be the name, the word for the day here. So, apart from being active, eating as well as you can, some people are going to present with osteopenia and osteoporosis, the severe form. So somebody comes into your office, Chris, what do you, obviously if someone has a fracture, an unexplained or a fracture due to a small trauma, I remember my grandmother was in a plane and the plane landed, she had a bumpy landing and she compressed 2 vertebrae. She was an older woman.
Yeah, and that gets me to, that scenario there makes me think about how we diagnose osteoporosis.
Let's go right into that, Chris. How do you diagnose osteoporosis?
And one of the ways we can diagnose osteoporosis these days is if they have a fragility fracture, independent of the bone density. We'll talk about how we do that with DEXA scan. But if a person has that collapse of the vertebrae, even if they have a relatively normal or a DEXA scan that's not in the osteoporosis range, if they have a fragility fracture that is a low trauma fracture, like your grandmother had, or like a patient I had not too long ago who was making her bed, slipped on a shoe, fell on her hip, and broke her hip. Now
making the bed,
which is a low trauma fracture. It's not like falling from a ladder or
right. She wasn't mountain biking.
So she had a fragility fracture. She has osteoporosis, and so the way we typically make the diagnosis is with a DEXA scan, which is a very low dose X-ray that looks at the density, at the 2-dimensional density of the bones, looking really at the mineral content primarily. But and so it gives us a great look at the density of the bones. It doesn't fully tell us about the strength. We talked about how the protein and the lattice of the structure inside of it will help change the strength of the bones. But that's how we diagnose it. And if it's normal, the score would be 0. And it turns out that a woman that is at her peak bone density or peak bone mass in her 20s, she would have a 0. And then people are, as you know, people are compared to that.
Well, let's explain that to people, that 0 is the reference. This is normal, healthy. We're going to call it 0. Right? We've got things called a bell curve. That's the top of the bell curve.
Yes. And if it's 0 to 1 is normal. 0 to -1 is normal.
Okay, and so between -1 and +1 in the normal, it's in the thick of the bell curve. Call it normal.
And that's the T-score. And then if it's -1 to -1 to -2.5 is osteopenia.
So as we're getting more and more negative, we're getting less and less bone density on these DEXA scans. Okay.
And less than -2.5 is osteoporosis. And these days we even have a category of severe osteoporosis, and that's -3 or less.
Oh, that'll get your attention. Well, it should get your attention.
The recommendation by the American College of Endocrinologists is for us to check women's bone density at age 65.
Whether they've had a fracture or not.
So
a woman comes at 65, getting her checkup, getting her blood pressure, basic labs and whatnot, should get a DEXA scan.
The issue with that is that 50% of women at 65 are not checked for osteoporosis. So there's a lot of people that are out there. And the other issue with that is we should be checking a woman before she goes into menopause or at menopause.
Right.
Why? Because if we don't know until she's age 65, that horse may be well out of the barn by then. And so some of the integrative techniques, the exercise, the nutrition, the supplements that are really supportive, they're less effective when the osteoporosis is severe.
Yeah, we want to catch it early like anything else.
And it turns out, if a woman has the diagnosis of perimenopause or menopause, insurances will pay for the DEXA scan.
They will.
And so I routinely do that in my clinic. Now, The other thing about it is how much radiation is in there. I always get that question from lots of patients.
Right.
And the thing to know is, the first thing to know is when you go in to get a DEXA scan, the person, the technician, is going to sit right next to you when they're doing the scan, and they won't be wearing any lead. So that tells you something that they don't have to protect. So it turns out that a DEXA scan is about 1/10 the radiation of a mammogram, 1/10.
Okay.
And it's 1/40th the radiation of one chest X-ray. So
Yes.
it's really, it's minimal. And a woman could have this, and sometimes we need to do it when they have osteoporosis, when we really want to check annually. They can have it yearly and have no concerns at all.
So it's a trivial amount of radiation. And people need to realize just being on planet Earth exposes you to some radiation. You get on a plane, it goes higher. You live in a brick house, your radiation exposure goes up. So the radiation exposure should not stop anyone or make someone fearful of the DEXA scan.
So the key is to get it early.
Get it early. Is there any time that you'd have a guy do a DEXA scan?
I'm glad you asked that. Well, if they have a fracture, for sure, and age 70. And so at age 70, it's recommended. Men tend to have bone loss about 10 years later than women. Women have a significant increased risk as they go into menopause with the loss of the estrogen. Estrogen plays such an important role. But I diagnose osteoporosis in men not infrequently by doing that routine scanning at age 70. And it's really good. Same thing with them, because then I can start changing their behaviors, or at least giving them the opportunity to do some weight training. And,
right.
Yeah.
Right.
So 70. Yeah, it's a good time for men.
Now, do you happen to know offhand what is the cash price for a DEXA scan? I didn't know I was going to ask you that, but that seems like an important question. For example, I just had a calcium score CT of my heart. I think it was $110.
So that is a terrific test. I love that you did that. It tells us a lot.
Yeah.
And it turns out that a DEXA scan, you can pay cash for a couple $100. So
$200.
So if a person, really would like to have it, and for some reason their insurance won't cover it, or if we're going to do it at increased frequency. So I have a few patients that have significant osteoporosis. The one I'm thinking about, severe osteoporosis, and they're on medication along with some of the other integrative things that we'll talk about for this. That we're going to do it at 6 months to just give them confidence we're heading in the right direction.
Can you start to see a turnaround in 6 months?
You can. Absolutely, when they're on medications. We use that term anabolism. We use some people with severe osteoporosis. The drugs we use, one category of those are the anabolics, and those you clearly see a difference within 6 months, right?
That's great to know.
Even with people that are very aggressive with their weight training, doing heavy lifting, the Lift More study teaches us what that heavy lifting needs to be.
Okay.
Those you can start to see a difference. Now, there's two different kinds of bone that we look at primarily. The cortical bone, which is the dense outer surface of the bone.
Okay.
And the trabecular bone, which is more this lattice structure that's in the interior of the bone.
Kind of a network, a lacy network. And is that trabecular bone, is that in the spine? Is that what you look at in the spine?
The trabecular bone is predominantly in the spine, though it's in other bones as well, like the hip. It does. The trabeculae follows the area of force. So the trabecular arrangement will be in such a place that it can absorb and tolerate compression and also bending, and that's got to do with the trabecular. It's more in the spine. So back to the question you asked, when can you see it? The trabecular bone changes relatively rapidly. So if I'm going to do that scan at 6 months or a year, I'm likely to see if we're heading in the right direction, I'm likely first see that in the spine.
Because that's the trabecular bone. Interesting.
Yes.
And on the hip, it's more cortical bone? Is that what you said?
The hip and the wrist is almost primarily cortical bone. The hip has both, but it's more cortical.
So if a patient is getting a DEXA scan, where do they scan?
We scan the lumbar spine.
Okay, the lower back.
The lower back.
Okay.
And then we scan the hip, both the femoral neck and the total hip, or the two scores we get there. The total hip is a more global score, and it's not so variable as this tiny area of the femoral neck that needs to be positioned absolutely superbly to get the great score there. And then we do the distal third of the radius. So if you put your hand right at your wrist at the top of your, by your hand, the other hand, that's So about 4 fingers up the wrist would be where we do the distal third of the radius. And those 3 areas, yes.
Okay, so they're not radiating your whole body. They're just going for these particular sites with these dual X-rays,
right?
And getting these readings. So you've got a patient, you suspect osteoporosis, you get the DEXA scan or a screening DEXA scan. Okay, let's say we have a patient now, they're getting into one of these negative T-scores, -2, -2.5. Now, do insurance companies give you any grief if it's 2.45 and it doesn't quite reach -2.5? Do they split hairs on you, Chris?
It depends on the medication that you might want to use. So the major classes of medications are ones that slow down the bone breakdown.
Okay.
Those are the anti-resorptives. And then the other ones are the anabolics, and that helps build. So, there's 2 primary cells, as you know, in the bones that are involved in the dynamism of the bones. The osteoblast, B for building bone, and the osteoclast that breaks it down.
Okay.
And so the inexpensive medications that we use for osteoporosis, the older medications called the bisphosphonates, they work on the osteoclast. They're pretty effective medications. They slow that down. So if you're thinking about being on the seesaw, if you slow the bone breakdown, then the bone building that will continue, then you'll get denser bones. Those medications are inexpensive. Rarely do I get any sort of negative feedback or denials to use those kind of medications.
Because most of those are generic now.
Right.
Yeah.
Absolutely. And then the anabolics are more expensive, but they really should be used more often than we're using them. And because they're more expensive, and often even you may need to get to severe osteoporosis, -3, before the insurance companies will allow that. The problem is that they're significantly more effective than the anti-resorptives.
Okay.
And so if you take a person, let's say a 55-year-old woman that has moderate to severe osteoporosis, and if I put her on a anti-resorptive medication like a Fosamax or a Reclast, we're going to get some benefit, but they really need to have bones that are going to take them in the next 40 years. They're going to get a modest benefit of 2 to 4% increase, maybe 5% increase in bone mineral density. If I use the anabolic medication, I might get a 10, 15, 20% increase over a couple of years.
So tell me about these anabolic medicines, Chris. What are we talking about? Injections of these new biologics?
They're injections, and they're based on the parathyroid hormone primarily. And they're a tiny little, they're given by an injectable pen. It's a angel hair size needle, so it's really virtually painless. And it's given daily, typically for 2 years. That's the prime, and those medications are called Tymlos and Forteo.
Okay, Forteo.
Yeah, and they've been around for some time now, and they're very, very effective. I've used them in many patients. And so I and many of the advanced practitioners of osteoporosis love to sequence these medications. Let's get the best bone mass we can with the anabolic, and then after we've achieved that for the patient, then we'll give them some of the anti-resorptive medications that kind of seal the bone there, so they can hold on to
you
it.
don't give them together, so you give a Forteo, and then you'll try one of these bisphosphonates, this risandronate, alendronate, something like that.
Right.
That's what you mean by a sequence.
Right. And
fascinating.
Now, in regards to getting that paid for, that can be a challenge. And these are expensive medications that people are, the very unusual patient would be able to get those, to pay for those cash.
Now, do you have any experience with these much newer biologics? Was it Prolia or?
So there's Prolia is denosumab, and it is a biologic, and it is in the anti-resorptive class. It's been around for a couple decades as well.
Okay.
And it's a good medication, and it can be effective. And actually, it's the strongest of the anti-resorptives. It's stronger than alendronate, Fosamax, and Residronate, Actonel, and it's stronger than Reclast. It's one I use often, but it has some caveats in its use. And here's the big one: is that whereas the other anti-resorptives, the bisphosphonate class that we talked about, those last in the system for a long time, right?
Yeah, they stick to the bone.
They do indeed.
Hard to get. By the way, it's hard getting them into you have to take it on an empty stomach in large amounts because very little gets into your blood.
Right.
But once it's on the bone, sticks real good.
It stays there for years, and that's a good thing because where the denosumab only lasts 6 months, and then it has an issue where that after that so if you're on it for more than 2 years and then you stop it abruptly, you can have a rapid deterioration in the bones.
I didn't know
and
that.
that can lead to fractures. So I like denosumab. It can be used safely in lots of different situations. It has low side effects, but it has that caveat. So a person has to be very careful about getting it every 6 months.
Oh, I didn't know that at all. So there's a rebound, and you got to be on top of that. Wow.
It makes for very hungry bone cells when it's stopped.
That's a good way to think about it. Now, I, as a reproductive endocrinologist, are very comfortable giving estrogen. Estrogen in women, especially if they're menopausal, will sometimes fire up bleeding again, menstrual type bleeding. People have been afraid of estrogen and various cancers, whether that's justified or not. And I know the trend over the past 10, 20 years is to give estrogen less and less to women after menopause. It's understandable, but estrogen also is very good at anabolism of the bone. So what do you do, Chris, as a family doctor who doesn't have necessarily a vaginal sonogram and endometrial biopsy capabilities? Or how do you look at estrogen in a postmenopausal woman who has osteoporosis?
I'm glad you opened up this.
That's a can of worms.
This chapter because I think it's a really important one. And so estrogen is a very powerful anti-resorptive. So it really slows it has some anabolism. It helps build bone, but what it does primarily is it slows bone loss. And when a woman goes in her perimenopause to menopause, in those next 4 to 8 years, she may lose 10% of her bone mass just because of the very rapid change. And that's why it's important to come into perimenopause and menopause with a really high bone mass.
And a plan.
And as we talked about before, to get that DEXA scan at age 50 so you know what's going on near your menopause. So the Women's Health Initiative, which is the biggest study ever performed in medicine, a $1 billion study, showed us initially, we thought, and I'm going to underline that estrogen increased the risk of breast cancer. So many, many women in 2002, when this came out, within a few weeks stopped their estrogens. Right.
Yeah, so in the arm that also had a synthetic progesterone in it.
Right. So there was a generation of women that only suffered menopausal-related symptoms that they didn't need to, but they didn't get the benefits of estrogen. So a detailed look by many different clinicians, including Joanne Manson from Harvard in the last few years, showed that when we looked at those women that took menopausal hormonal replacement therapy, they had no significant increased risk of breast cancer. Yeah. That there was no increased risk of all-cause mortality, and that's what doctors use for whether the woman dies from any reason prematurely, as compared to the group that wasn't getting it. So what we find is that estrogen therapy is for many women, maybe not all, but for many women, very appropriate if they're having symptoms, and if they want to prevent things like osteoporosis. It prevents colon cancer. It reduces the risk of cardiovascular disease. And if started early, it may reduce the risk of brain health-related and Alzheimer's-related concerns in women. Now,
that's been a real bone of contention. But let's just say it's controversial, and probably the effects are small. It's not like it's going to prevent Alzheimer's or something like that. But so you're not giving a blanket condemnation of estrogen at all. You will incorporate it in a plan for a woman if it's appropriate. Is that what I'm hearing?
Absolutely.
Okay, I'm glad we're getting back to the center now because the pendulum has swung both ways.
Let's circle back to the brain health thing. What the data tells us primarily is if you start it after 10 years, after a woman's been in menopause without hormone replacement therapy, after 10 years, that's when the increase of Alzheimer's disease went up from that. It was when it was started early, we actually saw changes in at least some of the studies. Some of the 8 major areas of the brain that are involved in memory there was more volume there in the women who continued to have the estrogen. I'm not saying that's necessarily the treatment for it, and I think just like you said, there remains controversy on this, that we need to learn about it. But I feel pretty confident that overall health in women can be improved, and bone health for sure can be improved by using estrogens if you have the data early on. And if they have other symptoms, and if it meets their medical mindset, Gil, that they're comfortable with
you
it,
don't want
right?
to force anybody.
And there's a great book out there that reviews all of this by Dr. Haven called The New Menopause. It was just published a couple of weeks ago.
That's why I'm so glad you're on here, Chris, because I have not kept up on this. I do just infertility nowadays. I haven't done menopausal medicine in 5 or 10 years.
Yeah. And so to bring it back, estrogen is a very important part of it. It is very important for a woman's health and clearly important in bone health. And many examples in my clinic where a woman will come in near menopause, she will have osteopenia, maybe even early osteoporosis.
Okay.
And I can partner with her and get her on estrogen, get her on a high protein, nutrient dense diet with lots of vegetables.
Okay.
Add some supplements that we can talk about here in a few minutes.
I would.
And then get her lifting weights. You know.
Oh, I love it.
So the exercises, just real quick on that, if we could.
Yes, please.
We know that being active, that walking and running and all of these things are great for our health, but they don't really build bone. That if you want to build bone, you need to lift things that are heavy. And this study called the Lift More study,
Perfect.
done by Belinda Beck, a PhD scientist in Australia, a couple of years ago, she took women in their 7th and 8th decades of life with osteoporosis. So they were, 7th, 8th, and 9th decades of life, so 70 and 80-year-old women.
Wow.
And they had them doing a progressive weightlifting program, starting with a broomstick, 2 major movements. One's called a deadlift. That's lifting a bar off the ground.
Okay.
And the other one is a squat, having weight on your shoulders and going up and down. So those 2 things, they load the body. They're a multi-joint functional movement. That's terrific. So they found that it helped the women have better balance, that over time they progressed the weight. Many of these women were eventually lifting their body weight off the ground.
That's a real deadlift.
They not only maintained their bone, they built bone. So what we know now, and what I recommend for my patients is to get a trainer that knows appropriate body mechanics and start a weightlifting program. It helps their physical health, it helps their balance, and it can help build bones too. So those things. Now, not everybody's going to do that,
right?
But that would be optimal. Now, I will say that balance is important. So things like Tai Chi and yoga that helps build your balance and make it less likely to fall, because mostly when we break a bone, it's when we fall.
Okay.
Right. So those things, and maintaining your muscle mass. So exercise is important. Walking's not enough, though walking is terrific. We all should, aim for that 8,000 steps a day or something like that if we're physically able.
Gotcha. But if you can add a deadlift, that's fantastic.
And the other thing about that, with both the squat and the deadlift, is in the spine, we're loading the spine with axial up and down compression. We're not flexing forward. The spine is at risk when you flex forward. So early on when they have osteoporosis, it's important, very, very important, that the mechanics are right, that you're loading the spine from top to bottom and you're not bending forward, because that's when people
torque. That's when an injury will occur.
Yes.
Important to know.
And they found not only was it effective, Gil, but it was safe. These women weren't developing fractures, right? And it made a difference in their lives.
That's great to hear. It is intuitive, but to have some data to say that it is safe, that's just fantastic. So let's circle back onto the nutritional recommendation that everybody gets, that women should be taking calcium and vitamin D. And the last I heard that the data just wasn't very good for that intervention only making much of a difference. Do you have any feelings on that, Chris?
Well, I hear that a lot. When people come to me, they often come to me for a second opinion. They'd like my integrative approach to bone health, and they will have been told that it's really important to get their calcium, really important to get their vitamin D, and that was kind of the keystones to treatment. I'll say that they're part of the treatment, but those aren't the keystones.
But by themselves ain't going to do much unless you're grossly deficient.
They're not going to lift many bone cells in the right direction. Yeah.
Thank you.
Yeah.
Thank you.
But the two P's, that is plants and protein, are going to make a difference. Doing some weightlifting is going to make a difference. You do want to have vitamin D, and for most people, you want a vitamin D level of about 50 nanograms per mil. That's optimal.
Yeah, I'm not anti-D, but there's many ways to get it, and if you have enough or you're replete, taking a little more probably won't make that much difference.
Yeah, I think we can overdo everything, but for the Institute of Medicine says that 4,000 IU is the safe upper limit. I recommend that for most women with osteoporosis because it's not going to get them in any trouble. If you get really high levels of vitamin D, you might get kidney stones. You could get more vascular calcifications. These things you don't need and you don't really want. So vitamin D, best to get it tested, but if you're not going to get it tested, if you're going to do just fine, it's going to be safe with 4,000 IU.
Yeah, I hear people freaking out. Oh, 4,000 because my pill has 800 units. It's like, I've never met a patient that's going to get hypervitaminosis with 4,000 units.
That's the Institute of Medicine saying that we should only give 800 IU.
Yeah,
and that's I think that's absurd.
That's not absurd.
That's not what I'm going to see in my clinic. Now, calcium's the other thing, and what we're told, and what many of us told our patients, was to go out and get supplements and take 1,200 milligrams of supplements daily. You don't need to do that. You need about 1,000 to 1,200 milligrams of calcium, mostly in your diet, and then you can supplement with that. And the supplement I like is calcium citrate. Citrate kind of it alkalizes the urine a little bit. It's good for the bones, the citrate part of it. And the calcium citrate comes at about 200 or 250 per capsule. 1 or 2 capsules a day is sufficient with a good diet. 8 ounces of milk has 300 milligrams of calcium in it. Almonds have calcium. Bok choy has calcium.
There you go.
Sunflower seeds. So if you're eating a whole food diet, you're going to get about 600 milligrams of calcium from your diet.
Okay.
So if you can supplement with 250, 500 more, you're going to get to that 1,000, 1,200 range relatively easily. Yeah. So those are 2 key supplements. There are others.
While we're on it, what do you like? What other little things would you add to the mix?
Genistein comes from soy. It's a soy isoflavone. And it's been shown that there's actually a medical food called a medical food. So this is something that's highly researched called Fostium that has that in it. So genistein is good. But you don't have to get the medical food. You can just get simply genistein, or you can eat 27 grams of soy food daily. That'll give you the 54 milligrams. So grams of soy, 27, will give you the 54 milligrams of the genistein that makes a difference. And genistein has an effect. It is a estrogen-like serum. So it indeed hits and activates the estrogen receptor in a positive way. So we like that. The other one is vitamin K2.
Please tell me about that.
And vitamin K. So there's a K1 that we all know about. That's the one that's involved in clotting in a big way. And that's what we get from our green leafy vegetables. And that's what you don't want to be taking a lot of if you're on Coumadin. Thankfully, that blood thinner, very few people are on it anymore.
Right.
But vitamin K2 comes in a couple of different forms. The MK7 form of it is the better form, lasts longer in the body. And you want something like 200 micrograms a day. And what MK7 does, K2 MK7, is it's really the calcium traffic cop. And so it pushes calcium to the bones into the teeth, and it pulls it from the arteries. It produces something called osteocalcin, which helps make the osteoid, the bone-forming matrix inside the bone cell. And it also, on the cardiovascular side, it turns up something called matrix GLA protein. And that actually pulls calcium from the cardiovasculature. So where do you get vitamin K2? You can get it from your food. You can get it from fermented dairy. You can get it from fermented soy, from natto, and some vegetables and things. But most people, if they're going to get enough, are going to need to supplement. Many good vitamin D supplements will come with K2. The one that we use at the clinic has that. So those are key supplements, the D, the calcium, the vitamin K2, the genistein, and the last one I use at times is taurine.
Taurine, the stuff that you find in energy drinks?
The stuff you find in energy drinks, but you don't have to get it from there. So taurine is an amino acid. It's a non-structural, non-essential amino acid
Okay.
that is has some great effects, and one of the effects is positive on bone. There's some other interesting effects in animal studies on longevity with taurine. So taurine, a couple of grams a day, is something that you might add last on the list. So when I think about taking care of these people, I think about the right food, the right supplements, the right exercise,
Yeah.
and then medications when needed. And some of those people, they may do just fine with the estrogen as their medication to add. Other people are going to need some of those bisphosphonates, those anti-resorptive medications, or those anabolic medications like Forteo and Tymlos. And I didn't mention the newest one called romosozumab.
Yes, yes. I forget the name brand of that.
Evenity.
Evenity, yes.
And Evenity is the most powerful one we have these days, in that it's both an anabolic agent, builds bone, and has a little bit of this anti-resorptive. So tremendous benefits. And we use that some in the clinic.
So you're starting to use that now?
Yes.
I imagine it's ferociously expensive. I imagine it's a monoclonal antibody.
And I didn't mention about my interest in osteoporosis. So when I was age 50, I had back surgery.
Oh, really?
Yes, and the surgeon told myself and my wife afterwards that he thought that I had osteoporosis, and indeed I did. Soon after that, I became very, very interested in the area, and then recognized, as I mentioned earlier, that many of the patients I had bones as well. So I became very interested in it. It turned out that I had celiac, and celiac is very detrimental to bones. So I took a short course of Forteo. My bones did really well. I did not want to take any further medications. And over the next 8 years or so, my bones deteriorated again until I really upped my protein, upped my lifting, and now I have healthier bones than most men my age of 64 without using any further medications. Using the supplements, the D, the K, the calcium, and a little bit of taurine, and I don't take genistein. I don't need more estrogen as a man at this point in my life.
Right.
But, yeah. And then from there, what I did is I got in contact with the University of New Mexico, who has a national program called the National Bone Echo Program. And this is a weekly meeting of physicians interested in bone health from major universities across the United States and the world. And we meet every Tuesday from 1 to 2:30 p.m. And that's how I continue to learn about bone health, and that's how I've been involved with that since 2017 and been to several national meetings. Great resource. Not too long ago, I had a case where I had a patient on the medication Forteo, and this was a man who bent forward, lifted a friend that had fallen, fractured a lumbar vertebrae in his 50s.
Oh.
And so I had him on Forteo, and after a year, I checked his bone density, and I noted the bone density in the hip actually decreased a little bit, though his spine was better. And so, as a part of this bone echo program, we do case presentations. So I presented his case, and the moderator said, "Kelly Crone, you did some of the original research on Forteo. Tell Dr. Link your thoughts on why this may have happened to this man's hip." And so, what was the point he made was that because the hip has cortical bone, it takes a little longer to make a difference with the Forteo, and you'll see the benefit at 18 months and 2 years, as I ended up seeing with this patient. But the beauty of it, Gil, is this resource is so replete with some of the world's experts in bone health. And to have a man that actually did the research, the original research, the clinical research on Forteo on the call that could answer the question, I was flabbergasted and very thankful. And I continue to enjoy that tremendous resource I have.
Oh, I'm so glad you're part of it, because I don't have time, or I don't make the time to be part of that. So that means you are bringing state-of-the-art information and standards of care to your clinic and to this area.
There's not enough university-based bone specialists to provide all the care, so we need this in the community, and that's what these echo programs are for. This echo concept actually started in Africa. because they had very few specialists, and we had to be able to get this information out. So they have a few specialists at the ivory tower, and then they have these where these community physicians or providers can present a case, and they talk about it, and then send this provider back off to provide excellent care. And now this is done around the U.S. right now in things like gastroenterology, infectious disease, endocrinology, and in osteoporosis. It's a tremendous concept, and it's useful in many areas.
Now, aren't you involved, Chris, in teaching here or residence? Or tell me about some of your teaching activities.
I speak some in the community, of course, and I have some lectures online. In fact, if anybody is interested if they go to my website at drchrislink.com, there's lectures that I've given. I gave a recent lecture to the Missouri Nursing Association on osteoporosis. That's available there. There's lectures on nutrition and GI health and other things on my website. But I teach in the University of Missouri Family Medicine program at Capital Region Medical Center.
Do they have residents down there?
They do indeed. And they do for sure. And there's been a program there for years, and I've taught in that program for the last 15 years, and I teach the Integrative Medicine curriculum. And so what I do in that for those residents is I help them have this literacy, this understanding that there's more potential arrows in their quiver if they understand nutrition and supplements and exercise to really augment family medicine, because their patients are going to ask them about these things. They'll ask them about what vitamin D to take, or if they should, or what vitamin K to take, and how to exercise, and what else they can do for their diabetes. Can there be a diet that makes a difference there? We know, you and I, that the ketogenic diet makes a big difference in diabetes management. So yeah, thanks for asking about that. Something that's a great joy in my life.
So your website, once again, is Dr. Chris Link, drchrislink.com. And we can put a link on the bottom of this video as well. So, Chris, we've been talking for about an hour here, and I believe we've hit the highlights. Is there anything else about osteoporosis that you'd like to talk about, or there may be any directions you see treatment going in the future? Can you get out a crystal ball and tell me where you see this going potentially?
The big area we haven't talked about is side effects, and I think it's important to talk about those real briefly, because
please do.
So the side effects potentially, and the things that worry people so much that many people forgo treatment. The one is called an atypical femur fracture. And the typical fracture that happens at the hip happens at the neck of the hip.
Right. So you've got the big leg bone, then it goes into a neck and a ball and socket. So it's at this little neck.
Right below that ball and socket is where it usually.
They call it the hip. I tend to think of hip as your pelvis, but it's actually of the femur bone, the neck of the femur bone.
Correct. And the atypical fracture is actually of the shaft, lower down, and it happens rarely, but it can happen with prolonged use of the bisphosphonates. Increased risk. The bisphosphonates will prevent 100 fractures for anyone they could cause. So that ratio is really excellent and keeps it low risk for people. But it's so frightening for some people that they forego that treatment. So that's one of the things I just really like to be able to explain to people about that. And interestingly, about the bisphosphonates, the way that in a sophisticated practice of osteoporosis management, you can use them by following. You can use less of them, and the less you use, you decrease the likelihood of that. So reclass is typically given yearly for 3 years. Often in my clinic, because I can follow bone breakdown markers, which are the bone turnover markers. And I can follow those, and if I can keep those in a range where I only have to give the medication every 1, 2, or 3 years, I reduce the risk even further than the 1 in 10,000. Right?
That's an IV infusion, isn't it?
It is, yes. Yes, it is. And then the other one is something called osteonecrosis of the jaw.
I was going to ask. That's the next one. A terrible complication. Teeth start to fall out and get bad.
Yeah, it's like an ulceration of the gingiva over the bony part above the teeth itself, and it can lead so bad that the teeth will fall out. but it's something that doesn't heal very well. This is very rare. I've never seen it in my practice, but it's frightening enough, again, that it keeps some people
you hear
away
about
from getting treated. But then we need to circle back that, it's really got to be a balance. There are some rare side effects that can be reduced by sophisticated management.
And avoiding it in a woman who already has a bad dental condition, I believe.
And knowing that the women that are at risk are men that are on those medications, they're already generally frail. They often have serious dental issues. They may be smokers. They may have alcohol use disorder. They may have cancer. They're frail. It's not the typical person that might get that, right? And once again, it can be reduced. So those two side effects can occur. They're low frequency, and we have to weigh that based on what is the risk of having a fracture and how that fracture may change your life. If a woman has, like your grandmother had, a fracture of her spinal vertebrae, 1 or 2, it changes her body habitus such that she's forward.
Yep. She got shorter every year.
Curved down.
Launched over.
And that changes several things. It changes lung capacity.
Of course.
It changes gastric capacity. Their chest can actually end up almost the lower rib cage can almost be on the top of the pelvis. So it just
it compresses. Nothing can work good in that situation.
And it also increases the risk of falling because it changes the position of their head and neck. So there's risks there that they have to think about. And the idea is to work with a clinician that can help them understand those risks and then individualize the care. Because some of those people may just need to have the right supplements and exercise. Some of those people may need estrogen on top of that if it's safe for them. Other people may need medications, but possibly those medications could be used in a way that they're exposed to less of those to have the great benefit. And then maybe for more severe people, they could even have them sequence where they get the strong anabolic followed by the anti-resorptive. And then the anti-resorptive in a limited fashion using the bone turnover markers to know where it needs to be so that I use the bone turnover markers with the careful evaluation of the DEXA in concert. And if both of those are heading in the right direction, I know that they're getting enough medication and I don't push it. I have some women that get the medication every 4 or 5 years.
That's all they need.
Yes.
Because you know how to do these bone turnover markers. Fantastic. Well, Chris, I am so glad that I have had a refresher course on osteoporosis. I'm so glad that you are bringing in information from the world leaders on your weekly ECHO program. And what a pleasure it is to finally meet you in person. I'm so glad you're here in the community. Your reputation is fantastic. And I look forward to working with you for years to come.
And let me echo that. It's been a great pleasure, Jill.
What a pleasure.
Jill, thank you.